Welcome to Living a Nutritious Life. I'm Keri Glassman, a celebrity registered dietitian nutritionist. Join me every Tuesday on YouTube and your favorite podcast platforms as I bring in some heavy hitters to share the latest in nutrition and wellness science. We dive deep into food, sleep, stress, relationships, and so much more. Your weekly guide to a happier, healthier, more nutritious life. Are you the friend who's always being asked for health advice? Now imagine turning that passion into a fulfilling career with our Become a Nutrition Coach program. Step into a world where your enthusiasm for wellness becomes the heart of your own thriving business. With me as your professor and guide and coach on our user-friendly digital platform, you can learn from anywhere at your very own pace. It's perfect for your busy life. Envision empowering others to live their healthiest lives, all while growing a career you love. You're not just gaining a certification here, you're joining a community of like-minded professionals ready to support and celebrate with you every step of the way. So what are you waiting for? It's time to nourish your future and help change lives, including your own. Head over to nutritiouslife.com/BNC for a free class and a sneak peek of the program. Your journey to becoming a nutrition coach begins now. Welcome. I'm Keri Glassman, and on today's episode of Living a Nutritious Life, we're chatting all about PCOS, a topic I have long wanted to discuss here on the podcast. In today's episode, I sat down with the brilliant Dr. Bojana Jankovic Weatherly. Dr. Bojana is a double board certified physician in internal and integrative medicine, certified in functional medicine, and founder of BOJANA MD, a boutique integrative medicine practice offering personalized evidence-based care. She shared her journey as a physician and a mom and how she came to create BOJANA MD and patient-centered personalized care she delivers. We spend most of the conversation discussing PCOS, its root causes, and practical strategies for management, from evidence-based lifestyle changes, labs to track, to supplements and medications. If you're a business owner in wellness or healthcare, this is a must listen to understand where medicine is heading and how to empower your clients. And if you're interested in PCOS, because you or someone you know is struggling, this is also a must listen for you too. So let's get to it. And as always, please rate, review, and share if you love the podcast. Hello, welcome to the Living a Nutritious Life podcast, Dr. Bojana. I am so excited to have this conversation with you today. I want to dive right in asking about your background because you have such an interesting, comprehensive background in traditional Western medicine as well as functional and integrative medicine. So love to hear your journey, your story. So let's start there.
Thank you so much for having me on, Keri. And absolutely, let's dive right in. So if you had asked me when I started my medical training if I was ever going to get into integrative medicine or if I even knew what that was, I would say absolutely not. I had no clue, very little to no exposure. And it was really during my medical training that a lot of these ideas completely transformed for me. And of course, as a lot of stories, it comes from my personal experience. So I had both of my kids in residency, which in hindsight was, it was just a lot.
A lot to say the least.
But so when I was pregnant with my daughter, really, this was the first critical point. I was in residency training. I was doing very busy shifts in the ICU where basically you're on for 30 plus hours. You don't sleep. You're admitting patients. I absolutely loved my training. I loved what I was doing. But at the same time, having chosen to also grow this baby and wanting to give it the most nutritious and the healthiest kind of start, that was a real challenge. And so I felt this increasing burnout and stress that ultimately culminated in one night, like a sleepless night, where I was like, I don't know what I'm doing. I don't know if I can do this. And I felt very much disempowered by this kind of struggle to how do I preserve this healthy baby and healthy pregnancy and at the same time meet the demands of the career that I've chosen that I love so much. And there were also some potential complications that my OBGYN was warning me about because both my babies were very large. We won't get into that. And I wanted to really ensure that I was doing everything I possibly could. And so so this culminated in this like very stressful night, and a couple of a friend of mine actually, and ultimately a birth doula that I decided to work with, recommended that I pursue some integrative medicine approaches. And this was a complete lifesaver and just a total paradigm shift for me, both as a physician and as a patient. And the two most critical things that I would say is, number one, the feeling that within this team, I had at that time worked with an integrative chiropractor. I worked with a prenatal yoga instructor, and also was starting to get acupuncture, which has, again, some evidence with respect to labor and delivery and so on. And with this team that I was so fortunate to have, I felt so empowered and such a part of the decision making, and really not as a passive recipient of their care, which unfortunately conventional medicine can often feel like, but as an active participant in what we were doing. The second thing was that these practitioners had the absolute belief in my body's ability to do what it needs to do. So if we're talking about a disease state, the body's ability to know how to heal if we provide the right ingredients in the right setting. And in my case, the body's ability to deal with this amount of stress and deal with all of this. This is what we're designed to do. This is what we absolutely have the capability to do. And it was in such contrast. And by the way, I love my OBGYN. He was amazing, but it was in such contrast to the regular conventional care. And this completely changed the paradigm of how I practice myself, with respect to really taking on, I mean, all care needs to be patient-centered, but really partnering with the patient.
I love it.
Looking at like, what are all of the different modalities that apply in this case that I can personalize to this individual, as opposed to, okay, here's a prescription, and this is, this is kind of the only thing within the guidelines, and I'm not going to discuss or research anything else. And that was a huge, huge shift for me that kind of started to open up that world for me. And then just through a series of experiences as a primary care, because I started off as a primary care physician, general internist, through a series of experiences of working with people, mostly women, who are coming in with chronic conditions and that are exacerbated by everything from lifestyle to genetics to stressors. I really felt like I didn't have sufficient tools with my conventional medicine toolbox. And I was curious about, there are many things out there, which some of which we'll get into. What is evidence informed? What is safe? Like, what is the safety? What is the efficacy? When can I apply this to this patient? Which ultimately prompted me to do the fellowship in integrative medicine and functional medicine, and to continue to really build on that without rejecting my conventional training, but with just bringing on, how can I additionally support the patient to really optimize their recovery, to optimize their condition and their health.
Right. And I think it's so important what you just said, without rejecting your conventional medicine training, because I think that is sometimes, I think, an issue. Sometimes people think like they're either all, this integrative or functional approach, and it means that they're anti-Western medicine and training. And it doesn't have to be that way. There really is this, as we talk about, integrative approach. But what does it mean to you to really have a full integrative approach? And how do you bridge that gap between conventional medicine and integrative medicine and functional medicine?
So this is what really prompted me to start my practice, because I really felt that I needed to design that setting where the patient is going to have the opportunity, number one, to tell their story, to be that active participant in their care, and then to engage in that shared decision-making as we go through, okay, what are the sensible evidence-informed options here? And what are they gravitating towards? What are their goals and values? And so it really was necessary for me to create that setting and that environment in which I will be able to support the patient. So number one, before people even come in to see us, we have long intake forms. I want to know everything about my patients, not just about their medical history, but everything from family history to past personal history, social history, nutrition, like all of it. I want to know all of it.
Right.
I want to know past medical records. I prepare for every single visit because I want to go into the first visit informed and prepared and understanding what are their health goals? What are their current challenges? What have they done before? So a lot of it is really about, number one, kind of building that full picture, as opposed to, unfortunately, the very little time that we're given often in the conventional system. And again, it's really no fault of the physicians. It's really just such a system issue. But but really creating that environment where, number one, I can hear that story. Like we can just start to kind of build that story and understand it. Because and I tell every patient, they're the expert in themselves.
Yes, I love that. I say that same thing. I love that. I love that. And it's funny, as you're saying, like understanding that full story, I'm completely aligned with you there. As a dietitian, integrative dietitian, I do a full, very comprehensive intake. And I say that same thing, that like you can do this intake and get all this detailed information on everything from medications to supplements to sleep to stress to all of these things to obviously food intake and all of that. But I always say, like, because when I'm coaching my coaches on this, I always say, like, you do this comprehensive intake and then you have to be able to step back and say, but like, what's like the big picture? I would say, like, what's the BP? Like, what's like the underlying big picture of what's going on with this person? And it might not be, what they first said, or it might not be that one thing, or where that number is low, or their weight is high, or this is that. It might, like, what's the BP? Like, what's the big picture here going on? So as you're talking about how you do this intake with people, it's reminding me, I feel so aligned with you there in terms of just like really getting this comprehensive understanding of the whole person. So sorry, continue. I just wanted to jump in on that.
Yes, no, I'm so glad to hear that, because it really makes such a fundamental difference versus when you're walking in, you really don't know anything. And then assumptions might be made, or there's just not enough time. And so this is kind of starts to build that. And then I spend a lot of time with my patients in each visit. We spend as much time as we need. And so this really helps to really encourage that dialogue. There's never any rushing. There's never any, because again, this is your health we're talking about. This is the most important thing. And so it takes time. It's not always just algorithmic. And, there are always layers that we have to peel back. So this is very helpful. And then in terms of, as we get into the diagnostics and as we get into specific conditions and as we get into the treatment plans, I really first we try to identify, okay, what are the priorities here, right? Like, we're not going to solve everything in one day. Right. This is going to take time, but let's prioritize, and let's also make sense of how are these different things connected, because oftentimes different symptoms will present that might be coming from the same underlying cause or several underlying causes. And so we start to look for those patterns and understand them. And then again, in my case, depending on what kind of workup they've had before, I'll review that and then I'll assess where I think the gaps might be and what else do we need to do. Is there anything that hasn't been checked with respect to lab work, with respect to any functional medicine labs that might give us a little bit more insight, whether it's microbiome testing in the stool, whether it's better understanding their cortisol levels throughout the day, whether it's deeper hormonal testing. We can kind of dive into some of these, but then we really kind of start discussing, okay, here is what's going to help me get a little bit more definition on this picture and really have a better understanding of what could be going on underneath. And so then we discuss, okay, this is the lab work and this is why we're doing it. And this is one of the reasons why a lot of the times with, standard lab, and sure, there are some things, standard of care, we absolutely check. But when it comes to standard lab panels, I typically don't do this prior to the initial visit, because there's no such thing as exactly standard. Yes, you're going to need absolutely all of these labs. We customize this. It depends on so many factors. And so again, it's personalized. And I think one of the things that's really important to me is the patient education component, right? Where right now, a lot of the population that I see, a lot of them there's so much information coming at us and a lot of, there's a lot of information from, direct to consumer marketing, from social media. Should I be getting this test? Should I be buying this supplement? And so a lot of it comes down to, okay, what does this mean? What are we looking for? And what I'm really big on is, how is this test that we're ordering, how is it going to change our management? If it's not going to change insight into your
Yes.
management, why are we doing it?
Yes, yes, yes. And I'm so happy you just said that, because I do think that over testing, and I've talked about this before on the podcast, I think that I'm all for testing and all for, knowledge is power and all of that. However, I think that there's so much over testing going on. And again, because people do have access to a lot of these at home tests, or they see, oh, so-and-so got this test done. And I saw that on, TikTok, and they see these tests being done. They think they need these tests, when I can say, yeah, well, you could go and I could recommend or suggest you get that test done. But no matter what it says, we're still going to do this, and this is still going to be better for you, and you're still going to feel better. This is still going to help manage your stress. So you don't necessarily have to do that. It's a waste of time and money. It's not going to change the management, like you just said. So, because I do think that that is an issue. And I think it also can then just complicate things and confuse people even more when they sometimes do the over testing.
Agreed. Absolutely. And for some of these tests that are available, I think it's also really important to share the new ones. So let's say if we are going to be using some actionable information, also understanding, well, what are some of the aspects of the tests that are experimental or that we still don't have a full understanding about? I think that transparency is and that understanding is so important, because like you said, we can have all these biomarkers, we can have thousands of biomarkers, but if we don't know what they mean in the context of that individual, then it's worthless.
Yeah, absolutely. Absolutely. I love your approach. I love it. And I love hearing all about it. And it's just, you're doing such great work out there. So, okay, I want to dive into a specific topic today. I was talking to you about this before we started recording, that I've been wanting to talk about PCOS on the podcast for a very long time now. And for whatever reason, just haven't gotten to it. But PCOS, polycystic ovarian syndrome, I think is for some reason has become, at least in my world, what I've seen with clients, with friends, and just, I don't know if it's maybe, I don't know why right now it just seems that it is everywhere. Even like we were just talking about social media, you're seeing people talk about it on social media. So then more people are coming to me and asking about it, but it just seems like more people are being diagnosed with PCOS. So I wanted to dive into why, how, what, how to, all of the above. So what is it, for those people out there that don't know what it is? What is it exactly? Is it truly on the rise, or are we just talking about it more? Why is it on the rise if it's on the rise more? And how do you manage it? But we'll get into the follow-up questions. But let's just start with, what is PCOS for people out there that don't know what it is? I mean, I just said the term, but you can dive into the details of it for everyone.
Yes, definitely. And you're absolutely right. It's a very common condition among women. It affects up to 12% of women, and it's the most likely cause of infertility, of anovulatory infertility, meaning when a woman isn't ovulating. So it's interesting because the name itself, right, polycystic ovarian syndrome, is a little bit of a misnomer, right? And it implies that it's a gynecologic condition where the ovaries have multiple cysts on them, which can be the case, but doesn't necessarily have to be. So in terms of diagnostic criteria, we have these Rotterdam diagnostic criteria for PCOS, and you have to fulfill 2 out of the 3 criteria to really be, to really have PCOS. So the first one is hyperandrogenism, meaning high testosterone levels or high levels of DHEAS, which is a testosterone precursor, or a manifestation of that. And a manifestation could be acne. Acne can be related to high testosterone levels. Similarly, what we call hirsutism, which is body hair or facial hair in women where it typically shouldn't be. So that's that first criterion. Again, not everybody satisfies that, since you only have to have 2 out of the 3, but that's a very, very common one. The second one that typically will be noticed first, and that a lot of women are concerned about, is irregular periods. So technically, the periods occur at more than 35 days apart, right? And there could be other reasons for this. But again, when I hear that a patient tells me, I keep missing my periods, or I haven't had my period for 3 months, this is definitely something that should raise a flag. Okay, could it be PCOS? And then the third criterion is that the polycystic ovaries, where on imaging, on ultrasound imaging of the pelvis, essentially there are multiple cysts or these follicles, these immature follicles that never really got to be mature eggs that got ovulated. So there are these multiple cysts on the ovaries that again can be there but doesn't have to be. And then recently on the criteria, that instead of that third one, the ultrasound, there was one added, which was anti-Müllerian hormone, which if that is checked in blood work and is elevated, that could replace the third criterion of the ultrasound. So that's been one fairly recent change in the diagnostic criteria. But a lot of the time, you're absolutely right. I'll see patients and maybe it's taken them a while to get diagnosed, or maybe they're not clear about the diagnosis. But in terms of the criteria, these are the three. But
And what about insulin?
Yes, so that's very interesting. So it's not in the diagnostic criteria, but it very commonly occurs. So this is something that I check as part of my lab panels, but it's very common that women with PCOS will have higher blood glucose levels, so pre-diabetes or diabetes, or at the very least insulin resistance, which essentially means that your pancreas needs to produce more insulin than what we expected to maintain normal blood glucose levels. So this is that we check, but it's not part of those criteria. And so we can't use it towards that, but it certainly happens. And similarly, these women, although there can be women with PCOS with lower end of range body mass index, oftentimes they're at risk of higher body mass index, BMI.
Right. Because of the insulin issue. Okay.
Exactly.
So I understand the diagnostic criteria. And I do understand also that not all women have cysts, which I think is something that when I was first learning about PCOS was interesting to me. But why do so much? I know you said that 12%, but are we just hearing about it more, or has that number been on the rise? And why whether it's on the rise or not, why do women have these issues? Like, what is the root cause of this? Obviously it's different in different people, but what do you see as the root cause of this issue?
Yeah, absolutely. So like a lot of things, which can sound really frustrating, like a lot of things, it's multifactorial, right? So, so there can be a genetic component. There are environmental components as well. And again, we see that association with a higher BMI. And sometimes, we ask, well, is it the chicken or the egg, right? Because a lot of the times, basically what can happen is with a higher BMI, that could be associated with more insulin resistance.
Yep.
That insulin resistance and testosterone levels can be correlated. So then the higher the testosterone, the more insulin resistance and vice versa. And so a lot of the times it's this never ending cycle. But what we really think, again, kind of going back to that initial assumption that it's a gynecologic condition, it really isn't. It's a metabolic condition. It is gynecologic in part, but it's metabolic. And it's also a neuroendocrine condition because it really affects our entire endocrine system. And so what happens in terms of this root cause, as we understand it, one of the things that's happening is that the signaling to our pituitary gland, and pituitary gland is responsible for making hormones such as LH and FSH, which ultimately signal to our ovary, and their patterns are responsible for ovulation every month. So that signaling is impaired to the pituitary gland. And what we get is often an imbalance where LH, luteinizing hormone levels, are high and FSH levels are low. And so this can cause this LH being high and FSH being low can cause these menstrual irregularities, but also this imbalance and this increase in this testosterone production from the ovaries. Testosterone can come from different sources, from adrenal glands as well, but here we're really talking about more testosterone from the ovaries. So what we want to do when we think about kind of how do we restore this balance, there's a metabolic component that we have to think about, because if we can regulate that insulin better, if insulin resistance is an issue in a person, then we can actually regulate that testosterone better, and vice versa. But at the same time, if we can restore that signaling and that LH and FSH pattern, which again, we'll get into, that can be helpful in terms of restoring those regular cycles. And then on the metabolic side, if we can really control metabolic factors, whether it's diabetes, prediabetes, insulin resistance, BMI, that can also help in restoration of regular cycles. But again, all of these things are intertwined. So we kind of have to work on all of these strategies at once.
Right. No, that makes sense. And also, and like you were saying before, that's why you do personalized medicine, is because every single individual is going to be their own unique case.
Mm-hmm.
So, and I mean, I think that's one of the things that makes this so complicated. So when you're treating someone, you're obviously, there's these different types of situations that occur with someone with PCOS. But when you're treating someone, because I know I can't just ask this like in general, like how do you treat someone? Because I know it's going to be so different and it is going to be multifactorial. So, but when you are working with, let's say, someone with PCOS, irregular periods, or maybe no period at all, where do you even begin? And I know you just sort of mentioned these different things, but what is maybe you can give us even a typical case? Like, are you using metformin to help with the insulin resistance? Are you using GLP-1s to help with that same, with insulin resistance as well? Like, what are your tools that you're using to address this?
Yeah. So the way that I divide up the tools is essentially, right, we look at lifestyle and nutrition, then we have supplemental supports, and then we have pharmacotherapy or medications.
Yep.
And then within each of these, there are going to be subcategories depending on what are we trying to achieve. So I can give you a few examples. So let's say if it's a woman that's coming in and she's not getting her period, right? Part of the concern that we have is that so her ovaries are not there, she's not ovulating and not producing progesterone. And part of the concern with PCOS is that if we have this unopposed estrogen, if we have this imbalance between estrogen and progesterone, this is going to adversely affect the uterus. And this could potentially adversely affect the lining. And we're getting all this estrogen stimulation, but then there's no progesterone. And so we want to protect the uterus from this ongoing unopposed estrogen stimulation. And so this is where we think about, okay, well, how do we restore this balance? And so the standard of care, so I'll talk about the standard of care and then kind of go into the different options. So standard of care will be, combined oral contraceptives, right? And they're achieving more than two things, but for simplicity, they're achieving two things here. One of them is going to be the estrogen component of that.
Right.
Actually going to be helping get the testosterone levels down.
Yeah.
And the progestin component, which is a synthetic progesterone, the progestin component of that can actually, support that unopposed estrogen. So now we're giving something to the body that it doesn't normally have, and at least restore the balance of these so that the uterine lining is not suffering as a result of excess estrogen. Now, even in choosing the combined oral contraceptives, I generally, even though again, if you look at the studies, this is not very clearly supported, but I think it's always best to use progestins that have the lowest levels of androgenic activity, because the trick is that progestins themselves can be androgenic, meaning kind of pro-testosterone acting.
Right.
I don't want to add that if the woman has acne already and hirsutism. So I generally use, if that's the choice, I generally use the oral contraceptives that are lower levels of androgenic activity. So an example could be Yaz or Yasmin.
Yep.
In terms of, now there are other options too. There could be progestin only options. So we're not adding more estrogen. We're just going to give the progestins to replace that progesterone. But again, we're giving progestin only pill, which is that synthetic progesterone. And again, this is gonna help too with that unopposed estrogen. But again, it's not going to have the benefit of lowering androgens, of lowering testosterone, because we don't have the estrogen component. But it's going to protect the endometrium.
But I have a question there for you. So let's say you put someone on that, they're 16 years old. Let's say a 16-year-old is in that exact situation. She goes on that. Okay, great. She starts getting her period. Her weight stays stable. There's no acne. We think this is a great solution. All's good. But then 10 years later, she wants to get pregnant. She goes off the birth control and she has the same problem again. It feels like it still feels somewhat like a Band-Aid.
Mm-hmm. So so this is part of the solution, but then we're also working on all these other things in the background. Exactly. And then the goal is, okay, well, can we restore regular periods?
Okay.
Can we restore a more balanced physiology? Exactly. So this is part of the solution, but not the full solution.
Okay.
So the other option, so sometimes patients will come and they'll say, you know what, I really don't want to go back on oral contraceptives. Maybe they had mood symptoms. Maybe they had breast soreness. Maybe they had other symptoms that they just don't want to go back to. Maybe there are certain, higher risks and whatnot. So one option that, again, this is where kind of the integrative comes in, is we also have the option of doing progesterone only treatment as an oral micronized progesterone.
Right.
So this is actually the same type of progesterone that we would use in perimenopause or menopause. The dose may be different, however, but we do that in a cyclical fashion. And the idea for this, and I actually, when we were writing up one of these articles, and we can link to some of the articles that we have.
Yeah, that would be great.
This up. It's interesting because there isn't a lot of research in this particular area, and I'd be so curious to see it because we are seeing success in our patients. But essentially, instead of giving the combined oral contraceptive or synthetic progestin, giving an oral micronized progesterone pill in a cyclical fashion.
So like 14 days on, 14 days off?
Exactly.
Okay.
So this is going to mimic what would typically happen in a period, because we see that in the luteal phase, which happens after ovulation, that luteal phase, we see a progesterone peak that then comes down. And so the idea is that we would mimic this, and that this would hopefully signal to the hypothalamus to restore that balance between the LH and the FSH. And that eventually then we can try again with the other strategies, but eventually then we can try weaning off. So this is another option that can work quite well. Again, it's something that's not the standard of care. It's not going to be, so it's not contraception. So if a woman is still having some ovulatory cycles, it's not contraception, but it can be a more, so to speak, natural, because it's not a synthetic progestin, it's progesterone, a more natural option of adding something that the body doesn't have, but it protects the uterus.
Have you ever looked at a skincare product and thought, I wonder if this is actually going to work? I mean, I think we've all done that, right? With OneSkin, I never wonder if it's going to work because I have real proof. Their whole company is led by scientists with backgrounds in tissue engineering, stem cell biology, and skin regeneration. And their products are backed by rigorous lab and clinical studies. The OS1 body is definitely helping my crepey skin, and I'm obsessed with the tinted OS1 Face SPF. It feels like butter going on, and it feels so good knowing that it's moisturizing my skin and protecting it all at the same time. I just love it. At the heart of their topical supplements is their proprietary OS1 peptide, the first ingredient scientifically proven to reverse skin's biological age by targeting cellular senescence. Those are those zombie cells that make your skin age faster than it needs to. Think about that crepey skin that we all want to get rid of. The research on their OS1 peptide has been published in peer-reviewed journals such as NPJ Aging. And not only that, the data for OS1 and their products clearly are listed on their website, so you can learn all about that and the incredible science behind all of their products. In lab studies, they've measured a 130% increase in collagen production with their OS1 eye cream. And another study showed that their SPF neutralizes free radicals, those are those bad guy compounds that I always talk about, 4 times more effectively than other so-called anti-aging sunscreens. The proof is in the numbers, friends. Try OneSkin and see for yourself. And you can get 15% off your first order with the code KERI, that's KERI, at oneskin.co/Keri. That's oneskin.co/Keri. It's complicated because every single situation is so unique. So what are, I guess, the standard labs that you are running? Like you were talking about labs before earlier in the conversation, like what are the labs that are a must when you think someone, either when someone has PCOS for sure, or when you're trying to diagnose them? Like what are those standard labs that you absolutely want to track?
Absolutely. So I'll use an example of somebody coming in with irregular periods where we don't necessarily know, just so that I can kind of share a little bit more about the full picture. So we definitely want to check things like TSH, thyroid stimulating hormone. And again, there's so much more to it because they're free T4 and free T3 and whatnot. For starters, just TSH, just to make sure that there's no overt hypothyroidism that's causing irregular cycles. We also want to check prolactin levels. Again, this is also produced by the pituitary gland, and hyperprolactinemia can be something that can cause irregular cycles. So again, we want to be aware of that. I do check LH and FSH. Again, another thing that's emerging actually in women under the age of 40 is ovarian insufficiency. And so we want to make sure that we're not seeing post-menopause type of numbers with LH and FSH being elevated in a very young woman, because again, that would suggest a different diagnosis, ovarian insufficiency, but we want to obviously be able to capture that and address that appropriately. So we'll check LH and FSH. And then I'm also going to check estradiol and progesterone. Now, there are ways to look at that. If you do check that, typically that should occur during the luteal phase of cycle, which can be tricky because if a woman is not cycling, she
you don't know when to test, right?
So sometimes, again, depending on the regularity of the cycle, sometimes I might even have them use an ovulation test so that they have an idea when they ovulated, and I might have them do it every couple of days for a period of time. Again, if cycles have been gone for too long, we have no way of predicting, so I'll just have them do it when they can.
Right.
But we can often see that estradiol to progesterone ratio, again, can be in favor of the estrogen, right? Because of that estrogen, we call it this estrogen dominant state, which also can be a little bit of a misnomer. But anyways, but so those are some of the labs that we would check. Of course, I always check a hemoglobin A1C because again, if I'm suspecting PCOS, this is important. And then fasting blood glucose and fasting insulin. Again, this is going to give me the ability to plug it into something called HOMA-IR, which is homeostatic model of insulin resistance equation. And if that's greater than 2, that means this person is insulin resistant. So those are some of the things that we want to check right off the bat. I do check testosterone levels, even if they don't report any hirsutism, meaning facial hair and so on, or acne. I will check that in DHEAS.
I was just going to say, you didn't say DHEA yet.
Yeah. So I do check those just because sometimes, again, on labs, they can be elevated, even if they're not having clinical manifestations. Right. Interestingly, again, I suspect this has more to do with the receptors and how the body is responding. And some people seem to have more acne and others seem to have more facial hair. But those are some of the ones that we'll start with. And then we go from there. And then again, we may do a transvaginal ultrasound to assess for those polycystic ovaries. But again, it's just part of the diagnostic criteria, but it's not needed. So I think that's really important to kind of note, because sometimes it's not totally clear that, that's not necessary.
Right. Okay. So you talked about the traditional, more traditional birth control. You talked about taking progesterone and cycling that as a more natural sort of way of management. What else? What other tools do you have in your toolbox? I'm specifically thinking about I know there's obviously diet and lifestyle aspects, managing stress, diet, regulating blood, managing blood sugar, eating consistently through the day. I want to hear your thoughts on all of that. But I also I'm curious about the different supplements that you recommend. And if you have a certain type of protocol like NAC, inositol, like what are your favorites when it comes to supplements?
Yeah, definitely. So again, some supplements will have multiple actions. Some will have, we're just using for, a specific thing. So we can start with inositol. So here it's really important. So with inositol, it's shown to help with ovulation. It can increase pregnancy rates in women that are undergoing ovulation induction. And it can also help reduce those male sex hormones, which is again, things we often see. It can also play a role in improving insulin sensitivity. But generally, I find that for insulin sensitivity, for prediabetes, diabetes, and again, you're a nutritionist, you know this, you really have to really work on nutrition and lifestyle. And it's so not fair because a lot of people with PCOS, they're doing such a great job and it's so not fair. They have to work so much harder than the popular population. And I acknowledge that. And I say that to my patients. They do such a great job. But unfortunately, no supplement is going to, make insulin normal. So it can be additive, but we definitely, want
to start with diet. Yeah. And listen, I always say that too. It's like supplements are going to supplement your diet and lifestyle. But if you're not doing the basics and the foundational things, then you're wasting your money. Like you really have to do those foundational things. And these might be that little extra boost, but they're not going to be, they're not miracle pills, right? So
exactly. They might just move the needle a little bit, but it's really the foundational lifestyle and nutrition. Exactly. So I'm a big fan of inositol. And actually the one thing just with higher doses of inositol, sometimes people can have some GI symptoms or bloating. So I just felt that, you can always kind of work your way up to the optimal dose. And here it's really important. And again, we can link to one of the articles that we wrote. It's a combination it's important that they use a specific ratio in a combination of myo and D-chiroinositol. This is what's been studied. And so I do often start that.
What is the ratio and how much?
The diagnosis. Yeah. So it's 40-1 of the myo to D-chiroinositol. And typically we work our way up to 2 grams twice a day.
Okay. So 2 grams twice a day. Interesting.
And oftentimes I give it as a powder. Inositol can also have some anxiolytic properties as well. And it really doesn't, you can put it in water. It doesn't taste badly or anything. So that's an easy one generally. Then we want to work through, let me actually back up and kind of work through some of the basics. So vitamin D, it's not uncommon to see vitamin D deficiencies in the regular population, but certainly in PCOS patients as well. So this we want to optimize. So typically, again, if we look at the general guidelines or Institute of Medicine, typically, under 20 vitamin D is deficiency, 20 to 30 is insufficiency. Typically, I like my patients to be a little bit higher in that range to really optimize that, to support regular normal blood glucose, to support bone health and so forth. So I generally go between 40 to 70, roughly. That's my goal. And so I'll supplement them with whatever they need to get there. And then omega-3 fatty acids. Again, this is really important because, again, oftentimes we can see higher inflammation rates. We didn't talk about HSCRP, C-reactive protein, which I actually do check as part of this panel. We didn't talk about lipids and that. We can get into that. But anyways, I do check HSCRP as part of this, and it's not uncommon to see C-reactive protein, which is a nonspecific inflammatory marker. It's not uncommon to see that elevated along with insulin resistance, prediabetes, elevated BMI. So that's something that's really important to work on. And so omega-3 fatty acids can help to reduce that inflammation. And then it can also help to balance some aspects of the lipid profile as well as the fasting blood glucose as well. So vitamin D and omega-3 fatty acids, those are like my basics. So now if we go back, one of the things that can be helpful, especially again, depending on how frequently they're cycling and how much this is an issue, Chase Tree Berry and Vitex can be a great option in terms of balancing and supporting that progesterone. And also if they're having significant PMS symptoms, this can be a very good natural option for that. The one caveat is that Chase Tree Berry is thought to increase LH, luteinizing hormone. So this is just something to kind of keep in mind if your doctor is tracking that, just to keep in mind. But we typically do use that kind of all cycle long, essentially. This is something that can help with PMS, with painful periods, with if there's any breast soreness from that estrogen dominance and so on. And then also infertility as well. Some of the other ones, if we kind of orient ourselves a little bit more towards the androgens. So we talked about insulin that can help with high androgen levels. Green tea or green tea extract. Green tea extract has some evidence. And the one thing that I'll say, and we've used it very successfully, and we see those numbers go down as part of the protocol. The one thing with green tea extract, there have been some case reports of liver injury. And this is something where I do check liver enzymes and just make sure that we track this, especially if somebody is staying on that longer. But that can reduce those testosterone levels very nicely. Green tea extract is also an option. Interestingly, also drinking spearmint tea every day has also shown to improve androgens. So I'll have people, that's like an easy thing to add. I mean, I guess iced tea if you're in this summer weather, but for my patients who do take it regularly, again, we do see a difference. And then soy isoflavones as well. They can also help with those elevated androgens. So I might prescribe that as well as a supplement. So those are some of the things that we'll commonly use. Again, if we're not having, especially if they're not on a combined oral contraceptive, so I don't have that extra estrogen that I'm giving, those are things that can be very effective for that testosterone. We didn't mention spironolactone on the conventional medical side. That's another thing that we can use.
I would love to hear your thoughts on that, because I do know many people that have been put on that and then have a lot of side effects that they're not happy with. So I know that that's an issue, and then people don't want to go on it. And I know that can cause all kinds of other issues. So I'd actually love to hear your thoughts on that. And do you ever prescribe that?
I do. I prescribe it. Again, I don't start with it. Again, partly it depends on what else are they taking. What are their numbers like? How much improvement, do we need to see here? I do prescribe it. The one thing that I would say I probably see the most often is that especially if they're on, one of the higher doses, blood pressure can go down, right? Because it's a diuretic. It's also used for blood pressure and heart management. And so sometimes we see that they're, if a person is on it, they might have trouble when they're standing up, they get dizzy, blood pressure will go down. We do check electrolytes on that medication because it can cause potassium to go up. Although I haven't, at the doses that I'm using it at, I haven't really had any recent concerns.
Wait, let's actually go back because I feel like we just jumped into that. And for anyone listening and hearing what we're talking about, I want to make sure listeners understand what we're talking about. So I was just asking about spironolactone as more of one of the conventional medicine approaches to PCOS. So can you just first now just again, go back and just explain like what is spironolactone and why you would recommend that or prescribe that rather?
Sure, absolutely. So spironolactone is a potassium sparing diuretic. So it's a diuretic medication, right? So we do expect that it's going to be, potentially making people more prone to dehydration, which is why we're sharing that it can cause blood pressure to go down or more issues on suddenly standing up. People might feel dizzy. But it's a potassium sparing diuretic. Typically, it's used for management of cardiovascular disease and high blood pressure, but it also has these effects where it's anti-androgenic. And so it can help to reduce testosterone levels. It can help in management of acne. It can help in management of hair loss that's related to elevated testosterone. So that might be the reason that we may want to add that in the mix.
Right. Okay, so there are all of these different tools, and we did sort of touch really quickly on diet and lifestyle, such as managing stress being important. But these are things that I talk about, obviously, all the time. I really want to hear from you, though, like what are your go-to recommendations for people? And of course, it's going to vary depending upon where they're starting from, what their diet is already like, what their stress levels are like. Are they on any medications for managing stress? What it's going to depend. But what is sort of like your go-to tools that you find to be most effective?
Absolutely. Just one thing that I wanted to say really quickly in terms of supplements along that line. We didn't mention berberine and chromium. So those are sometimes the supplements that I might use if I'm seeing this persistent insulin resistance and if I'm seeing elevated blood glucose levels as measured by hemoglobin A1C or fasting blood glucose. We may also add Akkermansia, which is a probiotic that can also help with reducing blood glucose levels. Again,
Akkermansia is also a big popular one right now because I think many people know that it also can help promote your own GLP-1. So I feel like, or maybe that's why Akkermansia has been having definitely a little bit of its own little 15 minutes of fame here lately as far as probiotics go. So anyone that's heard of that, that's why Akkermansia has been linked to improving your own GLP-1, which is, again, why I think it's hot, but why also it can be beneficial in terms of managing blood sugar.
Exactly. Yes. And again, on the magnitude of the change that I'm seeing in clinical practice, we can see things improve by a small amount, certainly when added to dietary and lifestyle strategies. But again, we're not talking the same kind of GLP-1 increase as if I were to prescribe Mounjaro or Zepbound or Ozempic and so on. But yes, absolutely. So we do use those three as strategies. And again, I always just one thing to kind of to be aware of, if somebody is on medications and they're considering these supplements, it's so important to talk to your doctor because there are drug supplement interactions. And if somebody is, let's say, on birth control and they think that that's going to be effective, and then potentially they add a supplement that interacts with that, and and it's not as effective, it's really important to know, what those potential interactions are. Or maybe you're on a supplement that can harm the liver, and also on combined oral contraceptive that can harm the liver. Watch those liver enzymes. The other thing that I love, and I personally love the taste of cinnamon. I put way too much cinnamon, but the one thing, it can help stabilize
blood sugar,
hypoglycemia as well, and that insulin resistance. So that's something that is an easy fix for people who like it in terms of adding it to your, morning meal. Generally, we recommend, and again, as a nutritionist, Ceylon cinnamon is generally thought to be more effective, but also less harmful because of the ingredient coumarin that, again, potentially can be harmful to the liver if consumed too much. So those are some of the things for glucose that we might use on the supplemental side. On the nutritional side, this is such a huge topic, the nutritional and supplemental side. So generally, kind of the main point is that we see that these individuals are just more sensitive to carbohydrate intake, and we have to be so strategic. And again, there's no one size fits all, because some people love time restricted eating or some other type of intermittent fasting. Other people don't tolerate it at all. So there are some very strict protocols that exist. And there was one study that came out, again, we can link to this as well, of like a very strict protocol of like the timing of eating and the calories and how you're doing the calories. And I was like, okay, this is great. This is great evidence that it can help with blood glucose, but who is actually
I was
going
just going to say, but if no one's going to do it, then it doesn't really matter, right? It has to be like what patient compliance is obviously the most important, because if someone's not going to do something, it doesn't matter. Like, it's even like food. If it doesn't taste good, if someone doesn't like, they're only going to stick with it for 3 days max,
Exactly.
right? So like, they have to like what they're doing, right? And in terms of like lifestyle, right? If someone loves breakfast and you're telling them, you know, to intermittent fast and not to eat until 1 p.m, that's not going to work. They'll do it for a couple of days. It's not going to work. You have to work within obviously what works for that person's lifestyle. So I'm so happy you said that, because I think it's like, well, this study showed that, you know, some people say that, and it's like, but if it's not going to help someone, if it's going to be too difficult, it doesn't matter what it showed. So yeah.
Definitely. I agree with you. And so here, you know, but the things we want to be mindful of, right, is that these individuals can be, you know, at a higher risk of elevated blood glucose, higher risk of high inflammation in the body.
Mm-hmm.
So we think generally our approach is anti-inflammatory foods, generally low glycemic index, meaning we really want to be mindful of that carb intake.
Yep.
And then what everybody's talking about nowadays, protein, make sure you're getting enough protein. The other thing that I didn't mention is that actually genetically, a lot of these, we didn't talk about leptin resistance, but a lot of these people might have leptin is a satiety hormone. Yep. And so if you have leptin resistance, you might not have that signaling of satiety and hunger.
You never feel full. Those people like that, they just never feel full and satisfied. They don't even know that feeling. And I've worked with people like them. Like I've never felt full. I feel hungry. I never have felt full in my life. Right. I mean, there are people that feel that way. So yeah, it's such an important point.
Exactly. And again, this is that, and I tell people like, it's nothing that they're doing wrong. This is literally just how they're programmed. Exactly. And this is what we have to work up against. And so thinking about, okay, well, how do we help them feel more satiated? You know, how do we add in more fiber? How do we make sure they're getting enough protein so that satiety and that caloric intake is really sufficient to keep them longer, you know, fuller longer, and make sure that they're getting enough nutrients. But as you said, really, there's no one size fits all, but we generally look at carbs, we look at sufficient fiber, protein, healthy fats, and making sure that those inflammatory markers are also coming down with an anti-inflammatory diet. So obviously diverse plants, lots and lots of plants, generally avoiding things like tropical fruit and things that are going to spike them. Ideally using a continuous glucose monitor, at least for a short period of time, to really see, you know, what are the things that are spiking them. And I think often that helps to kind of promote healthier behaviors, because if you see directly what's spiking you, you'll know to try something different next time.
Yeah. I mean, I love a CGM. The only time I don't like a CGM is when someone's trying to use it without working with a health professional, and then it just causes confusion for them. So I think like, you know, one of your patients using it, or someone working with myself, or, you know, a practitioner, I think it can play a really powerful role. I just think just mentioning that out there for people that, you know, you're hearing about them. If you're going to do that, work with someone so that at least when you get that information, you can digest and absorb that information properly and put it to good use and not let it confuse you. So yeah, this has been so fascinating. I could talk to you for hours about this, as well as so many other topics. So, but I know you're going to have to run too. One last question on this exact topic though, because again, we could go in so many different directions here. Metformin. Do you ever recommend metformin?
Yeah, so it's interesting. So metformin used to be used more to help with weight loss and to help with the metabolic component of PCOS. It's actually not recommended for that anymore. It is recommended as part of the fertility treatment. So I tend to, if I am working up against insulin resistance, that we can't completely reverse with dietary, lifestyle measures, supplemental supports, I'm actually more likely to recommend a GLP-1 agonist medication.
Yeah.
And so that is just more effective. And if the person tolerates it, if there are no contraindications, that's what we would typically go to.
Yeah. Well, that was going to be my follow-up question. So, and if you don't, or are you recommending GLP-1s more now? That makes total sense.
Yeah, I am. Now, in the case of somebody who has diabetes, metformin is still recommended to be the first medication that we try. And absolutely in that scenario, I would. But if we're just talking PCOS with no diabetes, and we want to optimize their insulin resistance, or their BMI is elevated, then GLP-1s is what I will typically do first.
Amazing. Thank you so much. This has been so informative. Last question for you. What do you do on a daily basis to ignite your nutritious life?
So for me, sleep is the foundation of everything. So if I didn't get my sleep, that's my number one. And then I have to, of course, I have to add another one, exercise. Like I feel like exercise and dance, it energizes me, and it just is like that keystone habit for everything else to fall into place.
I love it. Absolutely love it. Thank you so much. We will put all of Dr. Bojana's information, where to find her, and all of these links to these incredible studies that she mentioned in the show notes. So thank you so much again, Dr. Bojana, for being here today.
Thank you for having me.
Have you ever looked at a skincare product and thought, I wonder if this is actually going to work? I mean, I think we've all done that, right? With OneSkin, I never wonder if it's going to work because I have real proof. Their whole company is led by scientists with backgrounds in tissue engineering, stem cell biology, and skin regeneration. And their products are backed by rigorous lab and clinical studies. The OS1 body is definitely helping my crepey skin, and I'm obsessed with the tinted OS1 face SPF. It feels like butter going on, and it feels so good knowing that it's moisturizing my skin and protecting it all at the same time. I just love it. At the heart of their topical supplements is their proprietary OS1 peptide, the first ingredient scientifically proven to reverse skin's biological age by targeting cellular senescence. Those are those zombie cells that make your skin age faster than it needs to. Think about that crepey skin that we all want to get rid of. The research on their OS1 peptide has been published in peer-reviewed journals such as NPJ Aging. And not only that, the data for OS1 and their products clearly are listed on their website, so you can learn all about that and the incredible science behind all of their products. In lab studies, they've measured a 130% increase in collagen production with their OS1 eye cream. And another study showed that their SPF neutralizes free radicals. Those are those bad guy compounds that I always talk about, 4 times more effectively than other so-called anti-aging sunscreens. The proof is in the numbers, friends. Try OneSkin and see for yourself. And you can get 15% off your first order with the code KERI, that's KERI, at oneskin.co/Keri. That's oneskin.co/Keri.